For many cancers, surgery is central to diagnosis and treatment and is the only curative modality. Treatment delay can result in a missed opportunity for cure and can worsen outcomes. COVID-related delays in surgical care and a backlog of new cancer diagnoses will place unprecedented pressures on healthcare systems, particularly those like ours with a limited ability to increase throughput. We sought to quantify the cancer surgical backlog and the impact of the COVID-19 pandemic on cancer incidence rates. We did 2 studies tracking the use of surgery and cancer incidence before and during the pandemic using administrative population data from ICES. We identified cancer-directed surgeries from CIHI and cancer incidence from the Ontario Cancer Registry. We focused on changes that happened at the time of the emergency closure in the province of Ontario on March 15, 2020, which was designed to create capacity for COVID-19 care. We looked at changes comparing the pre-pandemic trends to changes that occurred at the start of the pandemic and until June 2020 for surgery and September 2020 for cancer incidence. We included 540,000 patients from 112 Ontario hospitals. As it relates to cancer-directed surgery, there was an immediate 60% decrease in the mean surgical volume on the first week of the pandemic. This decrease was followed by 6% increase in mean surgical volume each subsequent week. Surgical volumes did not return to pre-COVID-19 numbers by June 2020, resulting in 35,000 fewer completed surgical procedures in the peri-COVID-19 period than the same period up to June 2020. Compared with the pre-COVID-19 period, cancer surgery in the peri-COVID-19 period is more often considered urgent and performed more frequently at teaching hospitals and in inpatient settings. For our incidence study, the cohort consisted of 360,000 adult patients diagnosed with cancer between September 2016 and September 2020, of whom 37,000 were diagnosed during the COVID-19 period. At the start of the pandemic, there was an immediate 34% drop in the mean cancer incidence volume compared with pre-pandemic values. This was followed by a 1% increase in cancer incidence volume in each subsequent week until September 2020. There has been a large deficit of cancer surgical cases during the early COVID-19 pandemic, which have likely increased with subsequent waves. This has likely contributed to the deficit in cancer incidence as surgery and diagnostic procedures are also backlogged. These missed cancer cases raise grave concerns regarding real-world diagnostic delays. Delays in diagnosis for cancer are likely multifactorial: decreased access to seeing patients in person, imaging and cancer screening backlog, patient concerns about presenting in person related to the COVID-19 pandemic, decreased access to surgical care, including biopsies and surgical resections. Pandemic-related slowdowns of cancer surgeries are projected to result in decreased long-term survival for many patients with cancer. So what should we do about all of this? Access to surgery is a key quality metric for any healthcare system. Safeguarding access to surgical services during healthcare emergencies is required to avoid a lag in diagnosis and treatment of cancers. Creating capacity for increased surgical services is required, both in the short term to recover from the backlog, but more importantly, in the long term to safeguard against future healthcare emergencies. This is particularly important in a system like ours, which operates nearly always at capacity. Many cancers will present in a delayed fashion, and some may not be resectable or curable at presentation. Clear public health messaging is required, even during subsequent pandemic waves, to ensure that patients are seeing physicians when they have new symptoms and have reasonable access to diagnostic imaging and biopsy when appropriate. Screening programs should remain open and access to surgery should be prioritized for cancer cases. The health system should expect a surge of cancer cases during the pandemic recovery, many of which will present at a more advanced stage and will require more intensive treatment to achieve cure. As such, additional resources will be required to achieve equitable, efficient, and timely care for cancer patients during and after the pandemic. In preparation for future healthcare emergencies, additional resources are required to ensure that cancer care does not get disrupted.